Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Coming up on the podcast today, I'm joined by our deputy editor Nick Bostock.
Hello.
And senior reporter Kimberley Hackett.
Hi everyone.
To talk about some of the key news stories affecting general practice. We'll be looking at what went on at last week's England LMCs conference, including the results of some key votes on balloting the profession on industrial action, which could see GPs significantly escalate the steps they took as part of collective action last year and earlier this year. We'll be considering whether the profession will vote in favour of such measures and some of the other key concerns discussed at the conference. Nick will be explaining how the GP workforce has changed over the last decade. Now we've reached the landmark point of having 10 years worth of GP workforce statistics, numbers he's dutifully crunched and analysed for probably hundreds of news stories and analysis pieces for GP Online since 2015. And Kimberley will be highlighting this week's good news story, which is about a practice in Glasgow whose staff entered this year's Great Scottish Run. Before we start, just a quick message about one of our upcoming events. MIMS Learning Live North takes place on the 26th of November in Liverpool. The event will have 3 clinical streams providing practical and insightful clinical education delivered by experts. For the first time this year, we're also running a GP business stream at the event, which I will be chairing, and where we'll be looking at key issues including how general practice can get the most from the 10-year plan, the skills practice managers need to ensure the practice thrives, and advice on finance and CQC regulation. For more information and to book your place, visit mimslearninglive.com. And if you come to the event, do pop over and say hello if you see me. On the last news podcast, we were talking about the increasingly combative language coming out of the Department of Health, and in particular from Health and Social Care Secretary Wes Streeting and Health Minister Stephen Kinnock about online consultations and the dispute with the BMA GP committee. Last Friday was the England LMCs conference where GP leaders come together to debate a range of motions that help shape the BMA GP committee's approach to negotiations. As we said on the last podcast, a number of these debates related to stepping up action as part of this ongoing dispute. Nick, the mood at the conference was pretty angry, wasn't it? There was a lot of speakers very unhappy with the way the government has handled this whole issue of online consultations, but also lots of concerns about the future direction of travel under the 10-year plan and, this introduction of neighbourhoods. What was your sense of the feeling among LMCs?
We're going to come on to talk about some of the debates at the conference and what LMCs voted for during those debates. Some of those votes give a really clear sense of how many GPs are feeling currently, their sense of really having to sort of gear up for a fight with the government. GPs have been saying at these conferences for well over a decade now that general practice is in crisis, underfunded, with not enough GPs, workload soaring. But I think what we saw here was that any sense of optimism that came with a new government last year, sadly, seems to have evaporated, if not completely, then largely. LMC's conferences always open with a keynote speech from the head of the BMA GP committee, and they're often tub-thumping, powerful, but these speeches don't always set the tone for the rest of the conference in the way that this year's seemed to. This year's speech was from the BMA England GP committee chair, Dr. Katie Bramall, and the frustration, anger, disappointment, despair even, that she expressed over the current relationship with government was really striking. It's only 8 months or so ago that her committee agreed a new contract deal with the government, secured this promise of a substantive new contract by the end of the current parliament. But now, of course, the profession's in dispute over the way requirements around online consultation systems were introduced. And Dr. Bramall's speech was really bitter. She spoke about disingenuousness, duplicity, gaslighting, and what she called despicable attempts to flood the media with anti-GP rhetoric by the government in the context of the dispute that general practice is in at the moment. She said she saw no prospect of transformational investment to support general practice under the current government, and that's something that would be fundamental when it comes to that big new contract they want within this parliament. She said the outlook for the profession looked like it might only get worse under the current government. Dr. Brown was really angry about the BMA being frozen out of this review of the formula that defines how funding is distributed in general practice. And she said that while the government likely still wants a big new contract for general practice, her sense now was that they're not going to fund it, and that and we're not going to like what's in it. So, the extent to which it's going to be a sort of negotiated, agreed reform is being called into question. She also said that rather than invest in tried and tested GP services, the government seems intent on pouring money instead into what she called unevidenced emperor's new clothes neighbourhood models, and potentially funded in part with money that currently goes to GP practices. That's something we'll come on to a bit more later. So the mood was one of anger. Dr. Bramwell said the government had betrayed and lied to GPs. And ultimately, her speech was a rallying cry as well, a call for the profession to unite, to push back. And that's a call that I think was going out not only to the profession as a whole, but also to people within the room and within the GP committee that she leads.
Yeah, so coming on to the votes, LMCs voted in favour of some pretty significant steps that could lead to a ballot of the profession, didn't they? What exactly did they vote for?
LMCs have been talking for a while now about stepping up industrial action in general practice beyond the collective action that the profession took part in from August last year into the early months of 2025. And at this conference, there were a couple of votes that show sort of just how far the profession might be prepared to go to push back against the government. I think the standout motion, we talked about this on the last news podcast, was about the possible collection of undated resignation letters. LMCs voted to approve the GP committee going ahead with that move. And this is a tactic that was used most recently in Northern Ireland in 2017, but it hasn't been used since the 1960s in England. And to be clear, what we're talking about is the BMA asking partners at GP practices to send in undated resignation letters for their practice contracts. And the idea is that once a certain threshold is reached in terms of what the BMA is demanding, holding these letters from thousands of practices would give the BMA the power to threaten mass resignation at a certain time. I called it the nuclear option on the last podcast, but one GP speaker at the conference said he saw it more as a nuclear deterrent. GPs also voted in favour of a separate motion demanding a ballot on action including full-day walkouts. So we're talking about closing practices for a day as a form of protest, something that would breach contracts. And that's unlike the collective action that GPs have taken part in previously. In terms of next steps, then, what looks likely is that the BMA GP committee will discuss in the coming weeks how to take this forward. We know there's a meeting about 3 weeks from now, and we could see a ballot soon to determine the level of support among the wider profession for these sorts of steps, possibly other measures as well. Think about how that might go. I don't think it's necessarily a given that practices will vote for fairly extreme measures like this, although clearly LMCs feel there is an appetite for stepping up action. Some of the speakers against the motion at the conference, the motion on mass resignation, talked about the risk for partners who own premises, who have big mortgages and carry a lot of the financial risk around their practices, taking part in something like this. But at the conference, at least, the argument that the profession needs to give its leaders more tools with which to push back against the government won out quite clearly. So we'll likely find out fairly soon whether the rank and file in general practice feel the same way.
It's going to be interesting, isn't it? Because, I've spoken to some GPs who are not necessarily in that sort of LMC category of GPs, and the people at the LMC's conference are likely the people the most supportive potentially of some of these sort of more significant measures. And the sense I've got from people is that maybe, there's not necessarily an appetite for those very extreme things like handing in mass resignation letters or even staging walkouts. But the situation is quite bleak at the minute, and people do feel quite depressed about the state of the rhetoric coming out of the government about what they're being asked to do, and quite fearful about what the implications of the 10-year plan are. And these are people who are not sort of LMC type GPs, but we're going to come on and talk about the 10-year plan a bit more in a minute. Kimberley, let's bring you here. Ostensibly, obviously, this dispute is all about the changes to online access that requires practices to keep their online consultation systems on throughout core hours. We've talked about this on the podcast before. But basically, the BMA were expecting the government to agree a range of safeguards being introduced before this requirement came into effect. You watched that debate at the LMC's conference about this. What were people saying and what did they vote for specifically on this?
Well, there was understandably a real sense of anger and frustration from LMCs that the government just hasn't listened to GPs and included safeguards for the online consultations. GPs said that the government is disregarding safety measures and that it's more focused on promoting access to the public. They also said it excludes patients who may not have access to digital tools or be digitally literate. So it's no surprise that the LMCs unanimously voted to mandate GPC England to prepare options for forms of industrial action, including not complying with the online access requirements if the government didn't revise the 25-26 contract. They also backed the call to turn off online consultations when safe working limits have been reached, and LMCs also said they want to be able to deliver access in the way that is best for their patient population. But there was one GP who did oppose the part of the motion that called for the conference to reject the contractual requirement for GP practices to guarantee online access throughout core hours. Now, he was worried that if this was carried, which it was, it would encourage more GP bashing by the national newspapers and the government.
Which is actually what we saw, isn't it? Stephen Kinnock came out the weekend after the conference with some quite strident comments about the BMA and mentioned the Resident Doctors Committee and the GP Committee as part of that. And we'll put a link to that story in the notes for this episode. Kimberley, one of the other motions you watched was about the ARRS and GPs being employed under the ARRS. We're going to come on and talk about the GP workforce in a bit. And the government, very much wants to paint the ARRS GP roles as a real success story. It keeps telling us how many GPs it's recruited. But that's not what delegates at the LMC's conference see it as, is it?
No, they really don't. LMCs unanimously passed a motion that called to condemn the very introduction of GPs into the ARRS scheme, the low salary that some are on, and they also want to ensure that ARRS GPs are treated the same as those directly employed by practices. One speaker described employing GPs through the ARRS as a deeply troubling development for the profession and said that she knows of ARRS GPs who actually left their roles soon after starting because of the poor work structure. And we know that these GPs can be expected to work across up to 7 practices when the BMA says it should only be about 2 or 3. Then there is the pay issue. So one GP told the conference that she knows of ARRS GPs who are not only earning less than their also newly qualified peers in salaried roles, but some earn less than when they were in their last year of GP training. But the BMA England GPC member, Dr. Sarah Matthews, did tell delegates that the committee had pushed to widen the GP eligibility criteria to include GPs who had qualified within the first 5 years instead of the first 2 years. But this didn't come off in negotiations with the government. She also said that the BMA has been clear from the beginning that it would prefer a practice level scheme.
That is another issue. Unemployment for GPs, obviously another thing that's kind of feeding into this unhappiness amongst the profession. And Nick, we've both mentioned earlier that rumbling away in the background to all of this is the 10-year plan. The government's plans to introduce neighbourhoods and what that means on the ground for GPs and practices. We've talked on the podcast before about concerns relating to the new contracts that the government is planning to introduce. I think I mentioned on the last podcast that we're expecting a document setting out the model neighbourhood framework at some point in the next couple of weeks. That's supposed to set out how hospitals and general practice and ICBs are expected to work together. And there's also going to be a neighbourhood health planning framework coming out about the same time, setting out how the NHS should work with other partners. We might get some more details when those are published about how these new neighbourhood contracts will work. But clearly, LMCs are very, very worried about what this all means for general practice in the future, and in particular what it means for the partnership model. At the conference, delegates backed a motion that said practices should not participate in neighbourhood health provider structures unless they are led by general practice. They demanded that the move to neighbourhoods should be co-designed and led by general practice, and also called for adequate funding to deliver the plan, saying that any attempts to shift unfunded work to general practice should be resisted. The motion also called on the BM actually to develop guidance on how practices can resist involvement in neighbourhood models which undermine the partnership model. So this could be one of the options that might be on any kind of indicative ballot for action in the future. Nick, some of those actions you were talking about earlier were votes in response to actually a motion that was talking about protecting the partnership model. It was basically saying that the BMA GP committee should use any and all means possible to protect the partnership model. You wrote a story this week which really underlines just why LMCs are so concerned about the introduction of neighbourhoods, didn't you? Can you explain a bit about that?
GP leaders have spoken about neighbourhoods, and particularly the single or multi-neighbourhood provider contracts touted in the 10-year health plan as potential alternatives to the existing GP contract. I think the government slightly rode back from that since, in terms of them being alternatives. The point was that those were a real threat to the independent contractor model of general practice. Part of the concern here comes from a total lack of clarity around how these structures will be funded. As you mentioned, we're waiting for the detail of what these contracts are going to look like. And, so we don't know what they mean for the future of individual GP practices and, for example, the future of PCNs. There still hasn't been any official confirmation of how neighbourhoods will be funded, but concerns are taking shape around the potential for them to strip out some of the funding that practices rely on to remain viable. At the LMCs conference, there was a comment from Dr. Bramall, kind of in passing, about suggestions that funding for local enhanced services, so services that are outside the national GP contract, commissioned locally from practices, could be repurposed to help fund neighbourhoods. And then separately in October, in a webinar by a firm of specialist primary care lawyers, Hempsons, there was a discussion about the idea that directed enhanced services, so nationally agreed services, things like the PCN DES, which includes funding for taking part in primary care networks and hiring thousands of staff through the additional roles reimbursement scheme. It's a huge tranche of the funding attached to general practice. And then DESs also include services like vaccinations and immunisation work. So the sense that these lawyers had got was that they'd heard from reliable sources that this funding could also be stripped out of practice level funding and moved into neighbourhood contracts. If that happens, their view was that individual practices, are going to lose a really substantial proportion of their funding. And the question then would be whether that money comes back to them via neighbourhoods or whether it would be lost to other providers. Who else is going to be able to bid for that money? Where might it go? Who delivers the services that currently are provided by practices? If it goes elsewhere, practices are already under real pressure financially, despite the investment in this year's contract. We know that a big chunk of it went out again in increased costs. So the question is, how many might be pushed out of business by a change like that? As things stand, this is all speculation, really, because we haven't seen the final contracts for neighbourhoods. But it does seem that at the very least, discussions are happening around shifting part of the funding that currently flows to and supports general practice. Some of that could be redirected into neighbourhoods. And again, much like with that discussion around the future of the Carr-Hill formula, the funding formula for general practice, the BMA hasn't been able to get involved in that discussion about the future of that. And again, with this, the BMA certainly feels that discussions about shaping the future of contracts that are going to have a huge impact on the future of general practice are going on without them involved.
Yeah, I think that's definitely the sense that I've had from GPs I've spoken to, really, really worried about what this all means for local funding. But obviously, if directed enhanced services come into it, and I think that's always been a bit of a fear, hasn't it, from certain quarters, that all these, I've heard people say in the past that other providers would have their eyes on the ARRS money in particular, all those staff, because some of those staff will be quite crucial to delivering like a neighbourhood health service, particularly people like social prescribers, for example, about understanding local communities and helping to prevent people from getting sick in the first place. So I think there's a really big worry. And I think, when we see that document, that might actually focus people's minds about whether or not disengaging from this whole process is something they're prepared to do. But I think it would be a big step, wouldn't it, for practices to disengage from neighbourhoods. I mean, some PCNs and practices are already very involved in this new way of working and see it as a real opportunity to improve patient care. And I guess in areas where GP federations are pretty strong and leading a lot of local change, they might feel a bit more protected from potential changes that could come down the track to affect the partnership model. But it's clear there's quite a lot of concern about how some neighbourhoods are developing. I mean, actually at the conference, there were a couple of LMC representatives who said that they'd rejected plans in their local areas about neighbourhoods that had been put forward. But I do think it is a big risk not being at the table to shape any conversation about how things develop. That's what one of the GPs actually spoke against, that motion about disengaging from neighbourhoods. You know, he was saying by not staying involved, it isn't going to give general practice control. It will basically lose general practice influence. But I think that opinion was in the minority at the conference. There's a real fear, I think, that if hospitals lead the development of neighbourhoods, it will be bad news for patients, bad news for general practice, and potentially bad news for the NHS as a whole. Lots of GPs at the LMCs conference spoke about how general practice is the most efficient part of the NHS. I mean, we hear that time and time again. It's the only part of the NHS not in deficit. You know, if hospitals get even more control of health service funding, surely there's a risk of even greater deficits. And I think that's another cause for concern among GPs. Where is the money coming from to support this so-called left shift of services into the community? Would hospitals really actually hand over big portions of their budgets to community services if they're in charge? Is the money even there to do this if integrated care boards and trusts are already massively in deficit? On saying all that, I have spoken to GPs not at the LMCs conference, and while they are very worried about all of this, I didn't get the sense that they would disengage from the process of being involved in neighbourhoods. I got the sense that they felt they really needed to be at the table to help put the case forward for general practice and the fact that general practice needs the funding. But obviously, you know, this is all going to happen at a time where ICBs are shedding staff, and there's a lot of uncertainty about who is going to be doing what at that level. And we've had some more details about what's going on with that this week, haven't we, Nick?
Way back in April, ICBs were given 2 months to come up with plans to reduce their staff by 50% as part of the NHS reforms that the government wants to push through. But basically those plans have been on ice since then, because there hasn't been any clarity around how the massive redundancy costs that come with cutting such a huge number of jobs would be paid for. We're talking about 18,000 people potentially losing their jobs, and the cost of redundancy for all of those people is something like £1 billion potentially. Wes Streeting said this week that he'd agreed a funding plan with the Treasury to cover the cost of NHS redundancies. We're told that it's not new money. The funding's been found within the existing NHS funding settlement from somewhere. And we're told more detail will come in the next few weeks. But basically, ICBs have now been given a green light to go ahead and start the redundancy process, which brings to an end the horrible situation that lots of people in ICBs have been in for some time now, knowing their jobs were at risk, but not having any clarity about when their jobs might come to an end. But clearly, ICBs losing half their staff is also likely to have a big impact on general practice. You know, relationships will disappear, organisational memory will be lost. And the BMA's raised some big questions this week about whether the changes will undermine the government's 10-year plan goals and whether benefits to frontline care that the government's promised from this reorganisation are actually going to materialise.
So there's a whole raft of actions that GPs could take here that we've been talking about, a number of which would put GPs in breach of their contract. Before we come on to how likely it is that whether GPs would vote in favour of such steps, Nick, what's the government had to say about this?
The government's really doubled down again on the confrontation with general practice. We've talked before about ministers attacking the profession over pay and calling GPs laggards for being concerned about the impact of changes to online access. And following the LMCs conference, the government came out and accused GPs and the BMA of standing in the way of change. It said escalating the dispute would put patients at risk. It said GP's decision to vote for stronger action was founded on untruths. So now both sides are saying that the other is lying. The government says it's investing in GPs with this year's contract. GPs say much of the money went on increased costs. The government says it's hired 2,500 more GPs through the ARRS. GPs say, as Kimberley talked about earlier, that those jobs are underpaid. And the data actually show, anyway, that the figure is misleading. It's not quite as they say, and we'll come on to that again in a little bit. The government says it's put GPs at the heart of the 10-year health plan. GPs say the plan puts the partnership model of general practice at risk, and that, you know, obviously there's stuff about contracts that affect them, but they didn't know anything about. So we're in this situation where there are two parallel versions of reality, and that's driving a growing wedge between the government and GPs.
It's quite concerning, isn't it? The BMA have basically said that no progress has been made on any new substantive contracts. They're too busy at the minute trying to thrash out the whole issue about this online consultation situations. So that's quite concerning in itself. So what happens now? Will there be a vote? Do we know how that's going to work?
I think it's likely that in the coming weeks we'll see the GP committee discussing next steps towards a ballot of the profession. I would expect that to be an indicative ballot initially to gauge opinion in the profession over various different forms of action, probably covering options like collective action as well as stronger forms of action like the threat of mass resignation or walkouts. If there was an appetite for something like walkouts, because that would breach contracts, equally something like refusing to comply with the online access request, if there was an appetite for something like that, it would need a statutory ballot because of the fact that it breaches contracts to approve something like that. So there could be 2 rounds of balloting effectively to go down that route. But I think the indicative ballot is likely first, just because the BMA will not want to go for something like a statutory ballot and then find that there isn't the level of support required, because that would just be an embarrassing thing to happen in the middle of a dispute with the government.
Because contractual breaches, actions that would breach contracts, very different from collective action, isn't it? Because there's not really any risk to practice for that. The thing about collective action as well, there was something in it immediately for practices, wasn't there? If they were stopping doing work they weren't funded for, if they were implementing safe working guidances, the BMA could argue that taking these measures was in the long term of benefit to the profession. It's going to be much harder, I think, for them to get everybody on side behind measures that basically could threaten partners' livelihoods, really. So I think that is going to be a real challenge. I mean, one of the GPs who was speaking in that debate about signing undated contract letters said, as you mentioned, it wasn't the nuclear option. It's just about giving the GP committee something in their back pocket to hold over the government in negotiations. But, I'm not sure lots of GPs would see it like that. It's quite a drastic action, isn't it? As you said, that, the current environment is very different from the 1960s, which was the last time the profession did this in England.
It's hard to judge whether they'll go for something like this. LMCs are obviously the elected representatives of general practice, so they're likely to reflect the views of their members to a large extent. I think they're unlikely to have voted for actions that they don't believe their members would at least consider. Having said that, the cost of premises and so on are just on a different scale from the 1960s. So the kind of level of financial risk for individual partners is of a different order of magnitude now than it was then. There would be a lot of risk for partners now in taking strong measures like this, although, of course, arguably, there's a massive risk if they don't.
Well, a lot of it will depend on how people feel locally about how neighbourhoods are going, how much of a threat they feel this is to their practice and their livelihood in their area. And I think if lots of GPs feel that it really is a threat, they might well get behind some of these more extreme measures that we've been talking about. As regular listeners will know, we often talk about the GP workforce statistics on this podcast, which are now published every month by the NHS. Nick, this is very much a topic that you've written about for many years. And as I said in the intro to this episode, we've now reached the landmark of 10 years of GP workforce statistics, haven't we? What exactly does this data release show every month?
The GP workforce data is a snapshot of staff based on returns from GP practices. For the past few years, this data set, like you said, has been updated monthly. It used to be quarterly or every 6 months or whatever in the past. And it shows the total number of GP partners, salary GPs, retainers, regular locums, plus GP registrars. So a breakdown of doctors in general practice. And it also shows some things like the number of hours GPs work, and it gives breakdowns by age groups and things like that.
So the whole point of publishing these statistics in the first place was to get a decent grasp on what the GP workforce actually looks like, and then be able to plot progress against government commitments to grow that workforce. And there has been a lot of commitments, hasn't there, about growing the workforce over the past decade?
Yeah, they have. Probably the most well-known promise was from Jeremy Hunt, who made an ill-fated promise in 2015 to deliver an extra 5,000 GPs by 2020. You mentioned this data on the GP workforce stretching back over a decade, and basically there was obviously data on GP numbers before that, but the figures were sort of reset at that point to set the baseline from which Jeremy Hunt would deliver the promise. And his promise was based on what's effectively doctors in general practice. It's not just fully qualified GPs. So his promise was to grow the workforce based on a total that includes GP registrars as well as the fully qualified workforce.
Yeah, and looking at the data across the whole decade, what does it show? I mean, what does it show? It was pretty bleak for a number of years, wasn't it? An almost constant downward trajectory. But that has changed, hasn't it, in recent releases?
Yeah, by 2020, the date by which Jeremy Hunt had promised the extra 5,000 GPs, using his measure, including registrars, there were actually about 1,000 more. But looking at fully qualified GPs only, the total in that category had dropped by about 1,500. So it was a really big drop in, over the 5 years when he was promising that the workforce would grow. So the fully qualified GP workforce was falling fast, and it was only growing numbers of GP registrars, doctors who are training to become GPs, who do deliver consultations in general practice, but just not to the same level as a fully qualified GP and who have to be supervised by a GP. It was in growing numbers of that cohort that were actually keeping the total number of doctors in general practice up. In the past 5 years, though, GP numbers have recovered a bit. The fully qualified GP workforce is still down by about 850 compared with 10 years ago. But if you include registrars, as Jeremy Hunt did, the total is now almost at the level he promised, albeit 5 years late.
Yeah, it's quite funny talking about Jeremy Hunt again, isn't it? He popped back up after a long time not being someone we've mentioned on the podcast. But there's also been a fairly significant trend in the GP workforce over that decade, hasn't there? And that's been this shift away from GP partners towards salaried roles. The overall workforce graph may have turned a bit of a corner and be heading on an upward trajectory, but that's not the case for GP partners, is it? That's still heading down and down.
Yeah, absolutely. Partners are dropping fast still. In 2015, there were 21,655 full-time equivalent GP partners. And at that time, they made up just under 3/4 of the total full-time equivalent workforce. So now there are only 15,353 full-time equivalent GP partners, 29% down from the total a decade earlier. Salaried GP numbers, in contrast, have increased massively, up nearly 80% compared with 10 years ago. So you can see that, as increasing numbers of practices have closed, partners have been lost, more GPs have shifted into salaried roles. And as we mentioned, in the background to all of this, the number that's keeping that total number of doctors in general practice up is the number of registrars. So numbers of registrars have increased really significantly, almost double now than the number there were a decade ago. Another thing that we've seen is that both partners and salaried GPs have actually been reducing their contracted hours. It's worth mentioning it's not necessarily the actual hours that they work, it's the contracted hours, because we know that GPs often work way beyond their contracted hours. This reduction in their contracted hours is something that's been going on because of the intense growing workload pressure in general practice over the past decade. So in September 2015, 41% of partners, 15% of salaried GPs were contracted to work 37.5 hours per week, which is the measure of full-time equivalent, or more. In the latest figures, that number has dropped to 32% for partners, 8% for salaried GPs. But like I say, those figures aren't necessarily a representation of the actual hours that GPs work, because they often do more than their contracted hours.
There's all sorts of problems with this data, though, isn't there? And it's been compounded by the addition of GPs to the ARRS during the past year or so. We kind of touched on that earlier, didn't we? So despite these being official figures, they're not really a very clear picture of the actual GP workforce, are they?
Not necessarily. They're obviously a measure that's useful from the point of view of comparing with history.
Yes.
The figure that the government quotes in almost every quote from a government minister or a spokesperson at the moment, they have this claim that they've recruited an extra 2,500 GPs. So that is the total number of GPs who've been hired to jobs created through the Additional Roles Reimbursement Scheme since October 2024, when it was opened up to GPs. A lot of those GPs have since left those jobs. I think Kimberley touched on that earlier. The highest number of headcount GPs that there's been in any month since GPs were included in the ARS is something like 1,700. And the highest full-time equivalent figure that there's been at any point for any given month is 1,150, something like that. The issue with it is that the government says that it can't combine ARS figures with the overall GP workforce statistics. We know there's overlap. We don't know how much. We know that the overall workforce is apparently growing, but it's possible that it's only growing because of the ARS. It might be that numbers of GPs employed directly by practices are falling. It might be that they're slightly increasing, but we don't really know how much interplay there is between those two sets of figures.
Before we go, we've just got time for our good news slot this week, which is something Kimberley wrote about.
Yeah, so 15 members of staff from the Denbridge Medical Practice in Glasgow took part in the Great Scottish 10K Run. And the practice took on the challenge for a couple of reasons, one being the team experience and the other to encourage their patients to be more active from any starting point. In fact, the Glasgow-based 10K Run was chosen because it was felt that this distance would be good for people of all abilities.
Sure, it would work for my ability, I have to say.
So the team did really well and they finished in 13th place. The positives from this, it's so much more than just completing the race. Staff said that they actually found training together really helped with team building and fostering better relationships, especially for some of the newer members of staff who had recently joined the practice. In fact, it was such a success that the practice has now decided it will be a yearly event for the practice to take part in, with the aim of finishing in the top 10 next year.
Well, good luck to them for that. That sounds like a really amazing achievement, and we'll have to keep an eye on whether they do manage to get to that top 10 slot. Well, that's it for this week. Thanks to Nick and Kimberley, and thank you for listening. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.